there's a lot of things that can happen within the joint to cause peri-articular problems, and there's a lot of things outside the joint that can actually cause intra-articular problems, such as psoas, that we'll talk about in a little bit here. And what I'm going to look at is a lot of these peri-articular structures. So looking from the bony aspect of things, you've got the pelvic ring that's associated with the femoral acetabular joint, and there's not a lot of motion, but there's a little bit of motion. The sacrum nutates about 2 to 6 degrees by certain cadaveric studies, and that motion is very important for actually transferring forces up through the lower extremities to the trunk. And in the nutated forward tipped position of the sacrum, which is controlled by the erector spinae muscles, it's in a very stable position, and when it's counter-nutated, tipped backwards, it's in somewhat of an unstable position. Likewise, the symphysis pubis rotates a bit, and we're going to talk about how that is associated with some of the bony abnormalities about the hip. In the muscular layer, there's multiple muscles around the hip that can become involved all the way from the front, circumventing all the way around. And in the athletic environment, the three most common by a number of studies that we're involved with include the adductors, the rectus abdominis, and the psoas muscles, although, again, you get a large number of other ones. This is to reiterate what Dr. Millis just brought up, is that there's really this multi-layer approach to looking at the hip that we have to consider, and that you have the bony aspects of the osteocartilaginous layer, then to the more inert layer, which is the labrum and the capsule, and then moving out to all of the hip muscles around, and then even to the neural layer. I'm going to mostly spend my time in layer number 3 right here, and that was as described by Brian Kelly. So some of the dysfunctions that occur with hemipelvic dysfunction, and I think the term hemipelvic dysfunction really describes what happens very nicely, because if one thing goes wrong, you have a number of things that can go on around the hip. And certainly in the soft tissue, you have the adductors that can go out. You have this term athletic pubalgia, although some people feel that that's sort of akin, if you have a knee problem, to call it athletic nealgia. So it's a sort of a nondescript term, but goes in with some of the sports hernia types of things. Iliopsoas dysfunction, then you go out to the gluteal region on the side of the hip, which, and if you think of the gluteals, they're sort of the rotator cuff of the hip to help stabilize it, along with the small external rotators, and then the hamstrings, all associated with all of this osteocartilaginous layer. In the bony part of it, as mentioned, the osteitis pubis with the symphysis pubis, and in the back, the SI joint, and even at the lumbosacral juncture, there's forces that are imparted from the hip. So the adductor pain is really one of the more common ones that we see in athletes, and the adductor acts as an adductor of the femur, of course, but it's also an eccentric stabilizer of the hip when you're doing pivoting and twisting types of drills. When you have pain there, it'll typically radiate down along the medial aspect of the groin, but can actually come back along the scrotum too, so you have to be careful in thinking about that. And again, occurs a lot with pivoting and twisting types of sports and things that such as single leg stances. If you look at Per Holmick, who's probably one of the world's experts in the area of the groin adductor pain, they've done a number of studies looking at athletes, and of course it's somewhat dependent on what type of athletes come into your clinic, but in a fairly large study, what they showed was that of the three muscles that they see most involved, the adductor was the most common at about 58%, the psoas was the next most involved, and then the rectus abdominis is involved at least 10% of the time, with about 33%, or a third of the athletes, having sort of multiple muscles that are involved at the same time. The adductor pain is really usually elicited with weakness on adduction, so you can just start with that kind of a maneuver. Sometimes just putting them in the figure of 4 position and having them push up to the ceiling gets other parts of the adductor. They're usually very tender at the insertion. And if you look at the insertion of the adductor longus right at the symphysis pubis on ultrasound, on the right-hand side there, you can see a very disarrayed tendinotic tendon. It's a nice, easy office examination to look at. Tyler did a nice study, has done several nice studies looking at adductor strength and its relationship to the abductor strength. And what they did preseason was look at adductor-abductor ratios, and the adductor ratio in following these athletes through the season, the athletes with more adductor weakness, decreased ratio to the abductor was highly associated with pain syndromes. And then did a further study to show that if you did eccentrics, you could prevent injury as well as treat the injuries that actually occurred with those tendons. And of course, you always have to consider other etiologies, because the FAI syndrome can certainly be associated with this as well. And then I just make a point that certainly active stabilization per Holmick has also shown that the more active strengthening of the adductor is one of the best treatments for it, but that ultimately you can do a surgical release of the bilateral adductors, even for unilateral pain, with a pretty good 76 return to sport, which Mafuli reported in 2012. Now, moving right to the center, you have the symphysis pubis involved with osteitis pubis, and what the problem has been is that if you go back and look at Williams back in the 70s, he actually described that abnormalities about the hip motion were associated with abnormal motions at the symphysis pubis, but Varel and his associates looked at decreased internal-external rotation motion at the hip were highly associated with osteitis pubis, and Wang did a nice cadaveric study where they looked at FAI and found that FAI was very instrumental. It had a high association with increased rotational forces that occur at the symphysis pubis. So you can see how this transmission of forces across the ring there occurs with different abnormalities about the hip. And so sometimes you can treat just the adductors, but sometimes you have to look back and see what's going on in the hip joint itself. And moving to the same region is the sports hernia type of thing. And so what you have here is you have a confluence of tendons that occur with the rectus abdominis coming down from above. You've got the adductors coming up along with the gracilis, but the adductor longus is one of the more common ones, creating the ligaments that come across the symphysis pubis. So a lot of the problems that occur with increased forces at the symphysis pubis are also associated with forces and overdrive in the muscles across the pelvic region going from the rectus to the adductors. And so if you take a look at what sports hernia really involves, and there's a number of descriptions, but they all come down to the same basic area of this confluence of tendons. If you take a look in this area here, you have the conjoint tendon coming down, inserting into the rectus right here. You've got the inguinal ligament, and then you've got the transversalis fascia, which is the back of the cord. And this is the area that's of high interest in the sports hernia, where you get some actual bulging that occurs. And it can be due to tethering and tearing of the rectus abdominis as it comes down. It can be due to some of the motions, tight adductors, and some weakness of this transversalis fascia. So one recent, more popular description of what's actually happening is that you actually get some dilatation of this transversalis fascia that bulges out, increasing tension on the muscles that attach to the symphysis pubis, and some compression and irritation of the genitofemoral nerve. And the genitofemoral nerve comes out right above the rectus abdominis right there, and so irritation of that can cause this groin type of pain. And there's even some centers in Germany that are doing nothing but ablating that genitofemoral nerve to treat the sports hernia. The sports hernia exam is a lot of tenderness along that conjoint tendon, which is basically just above and slightly about a 10 degree more cephalad tilt from the inguinal ligament. So if you palpate right along the upper part of that inguinal ligament, you can feel the conjoint tendon. And then a scrotal examination where you feel for a direct hernia, but coming just medial to that with a Valsalva maneuver, you can actually get some tenderness. And all you're really feeling for is tenderness of that conjoint tendon right there to see if that's associated with that sports hernia. And then one of the more common findings with the sports hernia is pain on resisted sit-up. So if you're having pain in the sit-up position, I think this is a very sensitive exam finding for the sports hernia. If you look at it under ultrasound and you take a look at this line right here, the red line, that's the position of the probe looking a long axis view of the rectus abdominis that comes down over the symphysis pubis. You can actually see some thickening that occurs right through there. And then if you then just take your probe and come back up over the conjoint tendon right there and have the patient Valsalva, the white line drawn on the left there is normal, and when they Valsalva, you can see the specific bulging out right in through that area. All some more specific signs toward the detection of an inguinal, of a sports type of hernia. So Brian Kelly reported at the AOSSM, along with several other reports that were reported that year, looking at 38 athletes with FAI and that went to surgery because they failed conservative treatment. 32% had previous surgery for a sports hernia. And interestingly, of the athletes that had never had any surgery that had both FAI and sports hernia symptoms, 39% of them resolved with resolving the FAI issue at surgery. So there is a strong association. And then at the University of Virginia, there was another study reported, I believe in the same year, that looked at a number of their athletes with sports hernias and found that about 80% of them had FAI. So you can see there's this big crossover of motion, and maybe the sports hernia is really due to an overdrive of motion right there. Psoas now is an important muscle across for anterior type of hip pain, and we see that in ballet, kicking sports. Sometimes comes on with the athletic activity, but lots of times comes on afterwards and then can become worse and worse and more constant type of pain. Sometimes will actually radiate down towards the knee and may be associated with a snapping hip type syndrome. And what we see here is during that adolescent growth period, what happens is this pelvis rolls forward and increases what's called the pelvic incidence, which rolls and tightens up the hip flexors coming across the front there. And then if you have some muscular weaknesses that contribute to that and tightnesses, you can get into what John originally described as the cross-pelvic syndrome, where you have weakness of your abdominal muscles and glute max muscles, so you roll forward from that weakness, and then you have tightness of your hip flexors, your adductors, and your erector spinae muscle that may contribute to that as well. And then you can look at this under ultrasound, and you can actually, on the middle screen there, what you see is an axial view of the psoas coming over the pelvic rim. And I'm going to come to the next slide. And what's been described as one of the causes for snapping hip is where it actually, the iliopsoas tendon actually rolls into the bundle of muscle itself. And so if you take a look at this cartoon on the left-hand side, you can see the tendon. As you flex, abduct, and externally rotate, that tendon goes up into the muscle belly. And then when you look at it on ultrasound, as you start to extend the hip, the tendon comes down, tries to roll out, gets caught for a moment, and then snaps and thuds down on the pelvic rim right there. And so that's one of the causes. Deslandres described it in 17 dancers that he had. The psoas muscle is also, now we talked in the beginning about how some of the soft tissue structures can contribute to bony abnormalities in a reverse direction. The psoas has been described by some in a small number of cases where the psoas may actually impinge upon the anterior aspect of the labrum, causing a labral tear. Most labral tears from FAI occur up at the 11 o'clock to 1 o'clock position, as you can see down on the lower right-hand side, but the psoas comes down more directly anterior. So if you're a very direct anterior tear, right at the 3 o'clock position, that could be due to, as has been described as being due to a tightness of that psoas muscle that comes over, maybe becomes adherent to the capsule right there, and so that it pushes directly onto the labrum and can cause an issue. There's also a little muscle that goes along with that called the iliocapsularis, and just tightness of that is in that exact same position, which actually may be involved with that as well. Physical findings for hip flexors are a positive Ludloff test, where you have a seated position with the knee extended and go into a flexed position causing pain, and that somewhat isolates out the hip flexor, or the typical Thomas test, which I'm sure most of you know, where you can actually stretch the hip flexor. And then if you put in the bottom right-hand side, if you do the hip extension test, where you actually flex, abduction, externally rotate, and then bring it into an extended, you can get a popping or painful sensation that occurs with that. In terms of impingement testing for labrum, what we did a study looking back at our responses to injections a couple of years ago, and what we found was that impingement testing was a very sensitive test for labral tears, but it was also a very sensitive test for psoas signs. So when you get that impingement sign, it's really hard to know what is actually causing the pain right there. And then the rectus femoris, moving a little lateral to the psoas, can become involved with rapid ballistic and eccentric motions of the rectus femoris, and can pull either at the bone in the young athlete, causing a physeal pull right there, or in the more adult or even in the younger, can pull on the tendon, particularly at the central tendon right in that rectus muscle, and cause an avulsion. And if one has that, and you look at that under ultrasound, and if you take a look at that central slip in the middle of it, there's been a couple of studies that have shown that if you actually tear the central slip of that, your recovery period takes a lot longer than if you don't have that central slip involved. So an ultrasound is a nice way of sort of following along and seeing how you think how long that tendon is actually going to occur. And then, as Dr. Millis previously mentioned, if you pull on that anterior-inferior iliac spine with the rectus femoris and have chronic injury right there, what you may in fact do is create this ossification that can cause impingement when you bring the hip up into flexion. So that's another finding that has been more recently recognized as a cause of flexion-based hip pain from impingement. And then there's a bunch of nerves, and I'll just briefly go over these. You've got the ilioinguinal and the iliohypogastric coming down on this area right in through here, and then you've got the the lateral femoral cutaneous nerve going under the inguinal ligament right there, and that's commonly involved with too tight of a belt over there, but sometimes post-surgery where the scope goes past that, you can get a little bit of irritation, which will cause some pain and numbness on the anterior aspect of the thigh. And then there's a very small nerve that comes right over the rectus abdominis right here called the genitofemoral nerve, and that can cause some of that pain that's associated with a sports hernia. And then Dr. Millis later this afternoon is going to talk about some of the other things that you want to make sure that you don't miss, such as slip cap, et cetera, in the hip. Moving more laterally here, you have the gluteal muscles that are involved with pain syndromes, and you have the gluteus max, gluteus med, and the gluteus minimus muscle. And if one looks at a cadaver sort of view of that hip, what you have is this long facet of the lateral facet where the gluteus medius actually attaches, and there's a bursa that can live right up and through this area here, just near the piriformis attachment. There's the gluteus on the front of the hip, right in here. You have the gluteus minimus attachment to the anterior facet, and then the gluteus max doesn't attach to this posterior facet, but it goes over the top and attaches to the iliotibial band, and there's a large bursa back in here that can actually become involved with pain. So if you really, number one, needs a good clinical exam when you feel the lateral side to feel which one of those bursa that are actually more commonly involved with it. And so if you take a look and you put your probe onto the lateral aspect of the trochanter here, and you see this sort of V shape. In the front anterior part, you have the gluteus minimus tendon, and on the side, you have the gluteus medius tendon, and it occurs right in here. And then if you turn your probe long axis, you can actually see the glute. Well, in this case, the glute min is actually coming down more on the anterior surface right there. And then, in some cases, you're going to have hip abductor tendinopathy, where the tendon starts to degenerate. Usually occurs in a little bit more of an older athlete, but can certainly occur in the young athlete as well. And this is manifested by a lot of pain and pain with the resisted abduction. And there's also something called the derotation test, which is pretty specific for this, where in the supine patient, and the knee brought up to 90 degrees, and then the knee is actually externally rotated, and then you internally rotate the hip against resistance. That's specific for the gluteus medius, and that's called the hip derotation test, which is helpful in sorting that out. And one of the other findings for this is just a single leg stance causing pain right at that level, at that spot, is also fairly specific for gluteus medius tendinopathy. And right behind there is where the bursa lives, in case you're going to do a bursa. And sometimes we will do PRP, where we actually do a little bit of needle tenotomy into that area and to help treat that. But most of the time, your number one treatment, of course, is all the physical therapy and strengthening of that region there. Don't forget one thing, that hip pain from intra-articular pathology refers out to the side. And so as Dr. Millis very carefully brought up, when you get someone coming in with trochanteric bursitis, except for maybe the most transient of cases, I think that really you should consider getting an x-ray, because sometimes what's happening out here is reflective of what's happening on the inside of the hip. So for anyone with any kind of significant bursitis, I'll typically get a plain x-ray, an AP pelvis, just to make sure that situation is not happening. Now moving more toward the posterior aspect of the hip, you've got a number of small external rotators. Starting at the top here, you have the piriformis muscle, and then you have the small external rotators of gemellus superior, obturator internus, and gemellus inferior. The sciatic nerve comes out underneath of this and then lays over the top of the small external rotators. And you can get this piriformis hamstring syndrome, where anywhere along in here you can get some fibrous adhesions that have come along to the sciatic nerve and then pull on it, so that when you basically have sciatica-like symptoms, but a lot of tenderness and reproduction of your pain by maneuvers that stretch or palpate along that region right there. And starting at the top, you can actually see from the ischial tuberosity out from the sacral notch, you can see the piriformis quite nicely, and you can watch its motion and see how it relates to the piriformis muscle, to the sciatic nerve. And then if you take your probe down a little lower, you can actually, and that red line should be down over the obturator internus right there. The obturator internus, again, lives between gemelli superior above and gemelli superior below. Some people have actually described that as really one muscle with with three different insertions because or origins. So the obturator internus starts on the back side of the obturator foramen, comes up over, it makes the most significant turn in the body. It makes over a 90-degree turn that comes over that ischial ledge right there, and there's a little bursa that lives right underneath of it, and then you've got the gemelli above and below that. But they come confluently together, and that's again why some people have actually described that as one muscle. But there is a bursa that can become inflamed, and sometimes you can actually inject through that region. But obviously this is an area where you've really got to work on the internal and external rotational forces in treating that. Another thing that's been associated with decreased motion about the hip is hamstring tendinopathies and bursitis around the hamstring tendon. And the theory is that what happens with FAI is there's decreased motion, and so the body is trying to uncover it with more of a posterior pelvic tilt, and you get a very tight and weak type of hamstring, and more tendinopathy that can actually occur right up in that region there. And you can see the gluteus, the semimembranosus, which starts most medially, actually for its attachment site, comes up and sneaks most laterally. So even the conjoint tendon is more of a laterally based tendon. The semimembranosus comes up and actually attaches into a more lateral position above in that region. When you're palpating along, you can feel that. And here's just a visualizational view. On the bottom right-hand corner, you can see that there's some thickened tendon right at right over that ischial tuberosity, indicating some tendinopathy of the hamstring tendon right there. And then finally, looking back toward the very posterior part of it, the sacroiliac joint has been associated with increased pain syndromes with FAI as well. And because of that motion that's actually imparted, and you actually have to try to get more motion around the pelvis to get around that decreased motion around the hip. And you can look at this very nicely under ultrasound, and you can actually see the notch quite nicely if you're doing any kind of procedural motions right in that location there. And that's pretty much it. And the other thing that I just finally wanted to leave you with is, again, the pain referral patterns. I think that that's really one of the most important things that we have, is lots of times we have pain on the lateral side, the posterior side. Well, FAI, labral tears, dysplasias can refer pain all the way around. Then all of us have had the experience where we've injected and gotten temporarily better in, say, the gluteus medius, and then suddenly come back to find out, oh, it's really more the labral issue that's actually going on inside. So I'll constantly think about this whole number of things that can occur at one time and refer pain to each other. And I think that's all that I had to say. Thank you.